Hi, this is Piyush Bhargava and you're watching the whole body bone scan teaching file. Let's quickly review the clinical protocol. Whole body bone scan is performed to evaluate patients suspected of having bone metastases or to follow them up over a period of time after they have received treatment. The radiopharmaceutical used is 30 millicuries of technetium-99m MDP or HDP. The tracer is injected IV, we wait for 3 hours and we acquire whole body images of the whole body images in anterior and posterior projections. The mechanism of uptake is blood flow and osteoblastic activity. We see physiologic uptake in the bones, excretion of the radiopharmaceutical from the kidneys into the urinary bladder, and mild soft tissue activity. The critical organ for this radiopharmaceutical is the urinary bladder. Case number 1 shows whole body images in anterior and posterior projections from a normal whole body bone scan. There is good uptake in the bones. The uptake in the bones is symmetric. There is excretion of the tracer from the kidneys into the urinary bladder, and there is faint soft tissue activity. So those are the characteristics of a normal whole body bone scan. There is no abnormal focal uptake to suggest presence of osteoblastic bone metastases. Case number 2 shows anterior and posterior whole body images from a normal pediatric bone scan. The characteristic of pediatric bone scans is that the growth plates take up the tracer and they are intensely active, and at the same time they have to be symmetric left versus right. So we see uptake in the proximal humerus, which is symmetric, uptake in the proximal femur, uptake in the knees, the distal femur and the proximal tibia, and also in the ankle. So remember, in a pediatric patient, the epiphyses show intense uptake. Case number 3 shows anterior and posterior whole body images in a patient with osteoblastic bone metastases. There are scattered foci of intense uptake involving the skull, the spine, multiple foci in the ribs and the pelvis, and 2 foci in the right proximal femur, the femoral head, and also in the intertrochanteric or the femoral neck. So these foci are consistent with osteoblastic bone metastases. Another patient with disseminated osteoblastic bone metastases seen in the anterior and posterior views. This scan is approaching a super scan pattern where there is hardly any renal activity visualized, there is faint urinary bladder activity, and there is almost no soft tissue activity. So when there is diffuse osteoblastic bone metastases, there is intense diffuse uptake in the skeleton, and that pattern is called a super scan pattern. Super scan pattern can be either due to disseminated bone metastases or due to hematological problems such as myelofibrosis or other endocrine problems such as hyperthyroidism or hyperparathyroidism. The way to distinguish between these two categories is that with osteoblastic bone metastases, the bone mets are seen wherever there is active marrow, and typically that uptake ends in the proximal humerus and the proximal femurs in the extremities. But with hematological problems or endocrine problems, there is bone marrow expansion, and the uptake is seen diffusely involving the distal extremities as well. Here is another patient with diffuse osteoblastic bone metastases, again approaching a super scan pattern where there is intense uptake in the axial skeleton, and see how there is no uptake in the appendicular skeleton. Case number 6 shows a patient with osteoblastic bone metastases, and there is another characteristic finding here. This patient has an enlarged prostate, which we do not see here, except for the fact that it's indenting upon the urinary bladder and causing bladder outlet obstruction, because of which there is bilateral hydronephrosis and hydroureter. The osteoblastic metastases are seen in the skull, spine, and in the right side of the pelvis. Case number 7 shows a good correlation between the appearance of osteolytic bone metastases in a patient with metastatic thyroid cancer and their appearance on an I-131 whole body scan. So on the left we have anterior and posterior whole body images showing this focus in the spine, a focus in the rib, and what looks like a photopenic defect in that rib itself. Now when we compare this finding to the posterior view of the I-131 scan, since these metastases are from differentiated thyroid cancer, they take up radioactive iodine, and even though they are lytic on the bone scan and may show as foci of osteopenia, they will take up I-131 or I-123 and be seen here as a linear focus of intense uptake in one of the ribs. So here's an appearance of bone metastases from differentiated thyroid cancer on a iodine scan compared to a whole body bone scan. Case number 8 shows anterior and posterior whole body images in a patient where we see diffuse increased uptake in the bones approaching a superscan pattern, but the uptake extends into the distal extremities. So this is the pattern of superscan that we see typically with non-metastatic cause, such as hematological problem or an endocrine problem. Case number 9 shows another characteristic finding on a whole body bone scan where the extremities, especially the lower extremities, show linear increased uptake involving the medial and the lateral cortices of bilateral femur and the tibia in a symmetric fashion. This is called hypertrophic pulmonary osteoarthropathy, HPOA. It has several causes. For cancer, it's commonly associated with lung cancer, but it can be seen with other non-neoplastic causes as well. So when there is linear increased uptake involving the cortices of long bones in a cancer patient, especially lung cancer patient, the appearance looks like this, and the finding is called hypertrophic pulmonary osteoarthropathy, or HPOA. Case number 10 shows another interesting case where, looking at the whole body bone scan in an anterior and posterior projections, we find that there are several foci of increased uptake in the left side of the chest, and there are several foci of increased uptake in the pelvis. Now these were initially, when they were read, they were felt to be metastatic, although with metastatic disease we want to see scattered foci of increased uptake involving the spine, ribs and the pelvis, but these foci are localized. So because of that, this patient was referred for an FDG PET CT scan, and the two images on the right are from the FDG PET CT scan showing focal hypermetabolism, but the CT part shows sclerosis and a healing fracture here in the right superior pubic ramus and also in the left superior pubic ramus. So this patient had multiple fractures, and it turns out these fractures were insufficiency fractures, and this is corroborated by the findings from their bone densitometry, where, looking at their femoral neck, the T-score is less than -2.5, which is consistent with osteoporosis. So this is an appearance of insufficiency fractures on a whole body bone scan. Case number 11 shows a ring-shaped uptake in the chest. This is in the myocardium. Uptake in the myocardium is most commonly seen after a myocardial infarction. There is also diffuse increased uptake in both lungs or the chest, as seen here. This is secondary to heart failure and developing pleural effusion. So uptake in the myocardium from prior myocardial infarction, and diffuse increased uptake in the chest from bilateral pleural effusion secondary to heart failure. Case number 12 shows intense increased uptake in the right hemipelvis, and the right hemipelvis appears larger and expanded compared to the left hemipelvis, and this appearance is characteristic of Paget's disease. Another bone scan showing increased uptake in a vertebral body and transverse processes in a Mickey Mouse pattern, again characteristic of Paget's disease. There is also involvement of the distal tibia seen right here. Case number 14 shows another patient with Paget's disease who was followed when they were treated with bisphosphonates. The image on the left is before the treatment, where there is intense uptake in the left hemipelvis and the left proximal tibia. Look at the expansion of the bone and the bowing of the bone. Those two findings are characteristic of Paget's disease, and after treatment with bisphosphonates, we find that the uptake has resolved or is in the process of resolving. Case number 15 shows whole body images in a pediatric patient with sickle cell disease. Now with sickle cell disease, there's a phenomenon called autosplenectomy, and because of which the spleen over a period of time becomes smaller and may be calcified, and in that situation it can take up technetium-99m MDP, which we see here. Spleen is better seen on the posterior view, so here is diffuse increased uptake in the spleen. Since this is a pediatric patient, there is uptake in the epiphysis, which we see here in the upper and the lower extremities. Look how the uptake in the right upper extremity or the right proximal humerus is more intense on the left. The way to confirm it, if it is seen on the posterior view as well. So on the posterior view, we see that the right is more active than the left, and that means it's a true finding. And in a sickle cell disease patient, you want to worry about or raise a suspicion of osteonecrosis or bone infarction. Patient was injected with the radiopharmaceutical in the right forearm. That's the site of injection where we see that there was some infiltration, and because of which the tracer has traveled through the lymphatics, and we see uptake in small right axillary lymph node. Case number 16 shows anterior and posterior whole body images from a bone scan in a patient with rhabdomyolysis. Rhabdomyolysis is a condition where there is a breakdown of skeletal muscle cells, and if you do a bone scan in this patient, you would find increased uptake in the skeletal muscles in a symmetric fashion, seen here in bilateral thighs and also in the legs, and we see some of that in the upper extremities as well. Case number 17 shows whole body images in a patient suspected of having bone metastases. As we look at the scan, we find that there are no scattered foci of intense uptake to suggest osteoblastic bone metastases, but there are several findings: degenerative changes in the shoulders, sternoclavicular joints, bilaterally knees, and also in the ankles. You can see that this patient has an obese body habitus, and obesity is a common cause of degenerative changes in the lower extremities. There is excretion of the tracer from the kidneys into the bladder, but the interesting finding is right here, seen in the anterior view. There is a large focus of increased uptake, diffuse increased uptake in the pelvis, seems to be arising from the pelvis and growing into the abdomen. And we have two images from the corresponding CT scan showing a large uterus with multiple fibroids, seen here in the transaxial view and seen here in the coronal view, where the uterus is enormous. It's enlarged, growing out of the pelvis into the abdomen, and has multiple fibroids. Another interesting case, number 18. Here on the anterior image, we see this large focus of intense uptake in the neck, and not as well seen posteriorly because the activity is mainly located anteriorly. They don't have any bone metastases. There are degenerative changes in the spine. There are prostheses in bilateral knees. Injection artifact is seen in the left forearm. But this artifact is because they were previously treated with I-131 for toxic multinodular goiter. And as you know, the tracer that we use is I-131, which has a half-life of 8 days. So that can persist for several weeks. And if you do not know that history, you will not figure out what is causing this artifact in the anterior aspect of the neck. Case number 19 shows another artifact on a whole body bone scan where this patient was accidentally injected in the artery of the right antecubital fossa. So this is the site of injection. Instead of injecting into the vein, the technologist injected them into the artery. We waited for 3 hours. We did the whole body scan. Most of the activity has returned into the systemic circulation and is seen taken up by the bones, but there is still a large amount of activity seen in the soft tissues of the right distal upper extremity from accidental arterial injection of the tracer. Case number 20 shows whole body images in a patient with metastatic breast cancer. There are foci of increased uptake in the ribs, spine, and the pelvis, consistent with osteoblastic bone metastases. And what the finding that gives away the diagnosis is right here, seen in the right side of the chest. You see how compared to the left side, several ribs are missing on the right side. This is because this patient has received radiation to their right breast for the treatment of breast cancer, and radiation causes marrow replacement, and because of which there is no MDP uptake in this region, and that is a clue that this patient has history of breast cancer. Case number 21 shows an interesting artifact. This patient was claustrophobic, and as they were lying on the table and the anterior camera head was in front of them, they wouldn't tolerate it very close to their body. So the technologist had to move the camera head away from them, because of which the resolution of the anterior image decreased, and you can see that this is a sort of a suboptimal image. But the posterior camera head, which is behind their table or posterior to the table, was tolerated very close to their body, and the posterior image shows normal resolution. Case number 22 shows whole body images in a patient with history of bladder cancer, post-cystectomy, and a urinary diversion procedure. So we don't see any urinary bladder activity. The bladder has been removed. They don't have any evidence of bone metastases from bladder cancer. We see excretion of the tracer from the kidneys into the urinary diversion procedure, or the ileal conduit. So here's a part of the ascending colon that has been formed into a sort of like a urinary bladder. Another bone scan showing no evidence of bone metastases in the posterior and the anterior projections. The findings is right here in the region of the right kidney, where we see that the kidney takes up the tracer, excretes it, but we see a cutoff at the left UPJ. So this is how a UPJ obstruction would look like on a whole body bone scan. Next case shows an incidental finding of a horseshoe-shaped kidney on a whole body bone scan, seen here on the anterior image. It will not be seen on the posterior image because of the attenuation from the spine, and this patient does not have any evidence of bone metastases. More physiologic findings in case number 25, where we see diffuse symmetric uptake in both breasts. This is a physiologic finding. We see focal increased uptake at the inferior tip of the scapula. It's a symmetric finding seen here on the left and here on the right. Sometimes it overlaps with rib activity and creates what looks like an abnormal focus. In that situation, what we want to do is ask the technologist to get a spot view with the arms positioned above the head. Another artifact from injection infiltration. The patient was injected here in the right antecubital fossa, and we see scattered activity onto the left chest wall. Case number 27 is showing motion artifact. This patient was injected in the left upper extremity. There was infiltration at the site of injection, and during the acquisition they kept moving their arm up and down, and because of that there was this artifact. And then we got some more spot views of the chest with the arm outside of the field of view to get a better idea of the bones in the left lower chest. Case number 28 shows findings in a patient with hepatorenal syndrome. They have cirrhosis and ascites. Ascites is causing this diffuse increased uptake in a distended abdomen and pelvis, and hepatorenal syndrome is a common cause of diffuse increased uptake in a symmetric fashion in both kidneys, seen here on the bone scan. Case number 29 is showing diffuse increased uptake in both lungs and also increased uptake in the stomach. These are two sites, well actually three sites: the lungs, the stomach, and the kidneys. When there is diffuse increased uptake in one or more of these organs, think about a acid-base disturbance such as milk alkali syndrome, hypercalcemia, sarcoidosis, things like that. And usually it's not related to cancer, unless cancer is causing hypercalcemia, and because of that there is acid-base imbalance that can lead to this finding. Case number 30 shows utility of doing a SPECT CT. Here on a whole body bone scan, the only focus of increased uptake is this asymmetric increased uptake in the left SI joint compared to the right. When we did a SPECT CT, we found an osteoblastic focus in the left ilium, seen right here on the fused SPECT CT image. Another great utility of doing a SPECT CT along with a whole body bone scan is when you run into a situation like this, where on the posterior view there are multiple foci of increased uptake, and these foci could be from metastatic disease, but they are slightly laterally located, so could be from degenerative disease, and you're not sure. So you need some kind of morphological correlation. The best thing to do is to do a SPECT CT. The panels on the right, 1, 2, and 3, they show corresponding CT, SPECT, and fused SPECT CT findings corresponding to these increased foci, where we see there's an osteophyte that shows increased uptake, seen here. More osteophytes lower down in the lumbar spine corresponding to increased uptake, and these are degenerative. And also another focus more posteriorly located, seen here, and this is a facet joint. So increased uptake in a joint always is secondary to arthritis and unlikely to be from metastatic disease. So with SPECT CT, if you can localize the foci of increased uptake to degenerative disease, osteophytes, facet joint arthritis, then you will be able to rule out metastatic disease. Another similar example where we see on the whole body images increased uptake, seen here on the left side of the lumbar spine, and that increased uptake corresponds to this disc space narrowing, subchondral sclerosis, and osteophytosis, seen here, and all this is taking up the tracer and is all degenerative rather than metastatic. Case number 33, on the left we have anterior and posterior whole body images in a patient with osteoblastic bone metastases from prostate cancer. They complained of bone pain and they were treated with samarium 153 EDTMP for bone pain palliation. Samarium has a beta emitter that that is cytotoxic, and it helps in relieving the bone pain over a period of time. It also has a gamma emission that allows us to see the biodistribution of the tracer. And so the images on the right, the posterior and the anterior whole body images, show the uptake of samarium 153 in this patient who was treated for bone pain palliation. Case number 34 shows anterior and posterior whole body images in a patient with multiple myeloma. There are multiple foci of increased uptake seen here in the left proximal humerus, sternum, and also foci in the pelvis, consistent with myelomatous involvement. Here is a corresponding CT on that patient showing lytic foci here in the left ilium, in the the right ilium, the right acetabulum, and also in the left ischium. Case number 35 illustrates the importance of follow-up imaging, especially in a situation such as prostate cancer. Patient who presents with rising PSA. Their PSA increased from 11 to 24 in the last 6 months. Here is their bone scan. The first bone scan, which does not show any evidence of bone metastases. There is focal increased uptake in one of the ribs. Remember, for ribs, if the uptake is round or spindle shaped, it's consistent with a fracture. If the uptake is linear, that is considered more consistent with metastatic disease. They also have another focus here in the left proximal femur that can have a non-neoplastic etiology as well. Look at the follow-up scan. Now they have multiple foci of increased uptake in the skull, spine, ribs, and the pelvis, consistent with osteoblastic bone metastases. Now this was the last slide of whole body bone scan teaching file. I have gone over several patterns that you may encounter when you are reading a whole body bone scan. Remember, you have options of doing spot views. You have options of doing certain interventions such as moving the scapula out of the way by positioning the arms above the head, maybe putting 2x2s in between the toes to spread out the toes and get a better picture of the feet. You can do that. You can do a SPECT, and you can do a SPECT CT as well. Thanks for watching.